Okay, we are live. Welcome everyone, and thank you for joining us today for our How Lupus Affects the African American Community Symposium. Part 1 in our Lupus and Minorities Health Series in collaboration with Looms4Lupus and sponsored by GSK. I encourage all of you that are watching out there to tell us your name and where you're joining us from. Throughout the symposium, you will be seeing your comments featured on our StreamYard banner, so keep them coming. My name is Kelly Rosetta, and I am the creator of the Portland-based nonprofit, and the nonprofit named More Than Lupus, and it is a inclusive, multi-ethnic, multi-generational lupus community. So here at More Than Lupus, we seek to come alongside community leaders and organizations that are working and that have been working to educate and eradicate misinformation about African Americans and BIPOC communities, and have been creating initiatives to shine a light on medical disparities and improve access to care. We are thrilled to highlight the work that these incredible women are doing today. Now, today will be a time of reflection on past injustices, conversations about present barriers, and how we can partner together to improve health outcomes for African Americans and BIPOC communities living with lupus. It's my pleasure to introduce you to today's moderator, one of my closest mentors and a dear friend, Miss Anita Love. Anita is a lupus advocate, a community leader, and the More Than Lupus Board of Directors member. I'm now going to step off camera and hand the reins over to Anita. Thank you.
For that introduction. And as she stated, we welcome all of you who are participating in our virtual health symposium, that today we're going to focus on how lupus affects the African American community. Kelly said, I am a board member of More Than Lupus. A little bit about myself. I'm 68 years old. I remarried 6 years ago. I'm the proud parent of 4 amazing children who are, of course, adult, 11 amazing grandchildren, and I'm a native of Portland, Oregon. My passion at this time in my life is being a servant of God and advocating for those with lupus who are working to find their voice, and for all those who are dealing with chronic illnesses. I was officially diagnosed with lupus at age 40. However, I believe I probably had it 7 years early. With that said, it is my pleasure to introduce our panelists with us today. And I would like each of you to share a little bit about yourselves. And Dr. Edith Williams, will you start us off, please?
Sure. Thank you so much for allowing me to be here with you this evening. And it looks like your chat is already very busy and interactive, so that's wonderful to see. I am Dr. Edith Williams. I'm an associate professor of epidemiology at the Medical University of South Carolina, which is here in Charleston, South Carolina, on the East Coast. And my research has focused on developing behavioral interventions for mainly African American women with lupus over the last 15 to 20 years. And those interventions mainly focus on not only improving their disease outcomes, but also improving their quality of life. We've had a ton of success. We actually had a training earlier today where we're training a new round of mentors in a peer mentoring program that I'm going to be talking about a little later. On the personal side of things, I'm a wife and mother myself. I was just recently remarried last year, and my husband and I are having our first baby together. He is due in about 3 weeks. And so we're very excited. I have 3 other girls from previous marriage. And so this will be my first boy. So I'm ecstatic about this. We're very excited. So that's kind of what I've got going on in the background these days.
Well, thank you so much, Dr. Williams, for taking time to be with us today with all you have going on in your life. At this time, I'd like to have Dr. Jillian Rose tell us a little bit about herself.
Absolutely. Thank you for having me. I really appreciate the opportunity to always connect with this community. I'm Dr. Jillian Rose. I am the Assistant Vice President at Hospital for Special Surgery for Community Engagement, Diversity, and Research. I also oversee our ambulatory care center, where we provide care support for people of color, people with Medicaid, people with public insurance, a specific attention to minority communities. I also lead 2 national support and lupus education programs that are national and international: Charlotte Lupus and Lupus Line, which have been in existence since 1985, providing free counseling through a peer health model for people with lupus and their loved ones. I also partner with Dr. Williams, which is a great pleasure of mine. We're continuing to do her PALS program, and we both were in training. So I'm excited to round off our day with this conversation with all of you.
Thank you so much, Dr. Rose. And now we'll have the pleasure of hearing from Allie Henny. Miss Allie.
Hi, so I'm Allie, and I am a writer. I am a social justice advocate and educator. The space that I tend to work in is teaching people about inequities, about that sort of thing. I recently graduated from Fuller Seminary with a Master of Divinity, but my emphasis was race, cultural identity, and reconciliation. And so I do a lot of work in the space of advocacy for racial justice. I also have a personal blog that I write for. I have a Facebook page, so I'm just kind of there on social media. And then in my spare time, I am the vice president of a nonprofit called The Witness, which is a Black Christian collective. And so it's something that it's a faith-based organization. But in addition to being a faith-based organization, we really want to be in the space of advocating for people in the African American community and the Black African diaspora. And so that's what I do kind of professionally. But then personally, I am also a mother of 2. I have 2 daughters who are 6, and my youngest just turned 4, and I'm based in Chicago.
Thank you, Allie. That's exciting. Again, Kelly and I want to, humbly thank each of you for taking your day-to-day. So with that, we'll begin with a question for Dr. Edith. It's important that we have authentic conversations about the historical injustices our country has committed that have impacted people of color and compromised the health and well-being of the BIPOC communities. Dr. Edith, through your research, how have these injustices specifically affected treatment access, social support, and health outcomes for people of color living with lupus?
I think that's a great question. And I can't really say that I've uncovered anything that we haven't already learned over time through my research, but I can definitely speak on the fact that different trends that we've seen, particularly in Charleston, South Carolina, have definitely spoken to the type of research that I've decided to venture into and develop further in support of our African American communities who are still experiencing the aftermath of a lot of the historical injustices that you mentioned. So what we see is we do see poorer outcomes among our African American populations, particularly our young African American women. And that's a big reason why the interventions that I've developed over time, with the help and support of a number of colleagues, have focused on that specific population. So we see young ladies coming into our hospital system who are very sick, who are younger with complications that we normally won't see until later in the spectrum of lupus. And a lot of times this is driven by the distrust that is built up within their families and within their outlying communities, where they may receive a diagnosis or a suggestion of lupus, and their families will say, nope, don't go to that doctor. You're going to be a guinea pig. This is something they've developed. They're going to inject you with something. Don't take that treatment that they're recommending. And then these young people are then not adhering to the treatment regimens that could very well save their lives, or at least reduce the possibility of some of these long-term and life-threatening complications that we see them coming in with. So I believe that these historical injustices have kind of fostered that aura of distrust in these communities that now we as researchers, our rheumatology health providers are trying to combat. So we have a very unique situation in Charleston where we have a very supportive rheumatology team who is very invested and committed to our communities of color, even though they are not as diverse as we would like systems of providers to be, but they have committed themselves to be partnering with these communities of color that they know need that advocacy and need that support, need that encouragement, and need messages of trust and messages that they're in a safe space, and giving them the information that they need to feel confident about pursuing care with our team. So that's where my answer would be. It's more of an informative process where we see the effects of those events and we're responding accordingly.
Mm-hmm. All right. Thank you. Thank you. Dr. Rose, we all know this has been a year. And as we continue to wrestle with the, unnecessary deaths, merciless deaths of George Floyd, Breonna Taylor, Ahmaud Arbery, and so many others, as well as this global pandemic we're dealing with, and a presidential election that has deepened, the pluralization in our country. How do you see your role and your services at HSS, Hospital for Special Surgeries? What have you been offering to utilize to rise up and meet these challenges at this current time?
Absolutely. The events that you've mentioned were all televised, right? And they weren't just televised at a time when we were all concerned about the busyness of our day, right? They were televised at a time where we were under siege by the COVID-19 pandemic, under siege and in our homes. So many of us, nationally and internationally, were glued to our television when we heard about George Floyd and when we saw the gruesome videos, when we heard about Breonna Taylor, when we heard about Ahmaud. Not to say there are many more people, a long list of people that we can go through who haven't bear the brunt of this similar type of injustice. But what was different here about what we witnessed as a collective, as a country, you had more eyes on the television screen. And as a result of that, as many organizations are doing right now, right, we at HSS had a chance to stop and reflect on who we are as an organization, and then who we would like to be in the space of equity, as we seek to serve a diverse patient population, and as we seek to serve and attract world-class partners, our clinicians, our staff, to provide more equitable care. First, we were able to assess the pulse, the thoughts, feelings, and concern of those on the ground who were working at our institution. We wanted to hear from our colleagues. And I have to tell you, our CEO and leaders really played a pivotal part in opening up listening sessions where the top of our leadership was attending those sessions with staff to hear about what we can do better. What were their experiences beyond the walls of HSS? We were then able to commission a diversity, equity, and inclusion council. And we hired an outside partner to help us to set goals around enhancing access to care, attracting a high-class, diverse workforce, and deepening our commitment to healthcare disparities research. And those things all came from the voices of the people who were invested most in HSS. And that's our staff members who are on the ground providing care and coming from the communities that are most affected by some of these injustices. Right? But first, we all had to get on the same page. We're talking about this concept of equity, and we each have a different meaning of what that is. So it was important for us to partner with an outside firm to educate our leaders across the hospital body, both our medical leadership as well as our staff leadership, around implicit bias, the idea of belongingness, and to shift our thought process to a growth mindset in terms of how you develop a culture of inclusion. Our organization now is at the phase where we are seeding the entire organization. It's mandatory for everyone, every vendor, every staff, every medical clinician, to take a training called Inclusive Culture. And that training also includes tenets of anti-racism, bias, discriminatory behavior, awareness of the impact of disparities. And so from that, we all will be able to not just say, let's let you in the door, right, to receive service. But when you get into the door, it matters what your experiences are as a patient. Are we treating you with dignity and respect? Are we moving to those cultural considerations? Are we making sure that we're giving the resources that's needed to dispel some of the disparities that you face, or social determinants of health that is going to derail the treatment plan that we just talked about once you get home? So that's the stance we're taking now, a holistic stance of culture shift to examine our own practice and behaviors. But not only that, that really starts with us.
Thank you. And that sounds exciting. Ms. Henny, one of the biggest barriers hindering access to appropriate treatments and quality healthcare in communities of color is the alarming level of medical gaslighting that takes place in a doctor's office or a hospital setting. Can you define to our viewers today just what is medical gaslighting and what steps to identify it and hopefully avoid it when it is happening to you?
So a simple definition for medical gaslighting would be whenever a healthcare provider doesn't believe a patient or the other, but maybe they have a caregiver or something like that who's accompanying them to an appointment or in an emergency situation or something like that. And they don't believe the symptoms that the patient is experiencing. Maybe a patient says, I am, you're in an emergency room situation, you're saying, you know, I have lupus, or I'm taking this type of medication, and the medical staff ignores you, or they don't act like they believe you that you have a condition or something like that. There's also an element of minimizing, where if a person is saying, I'm experiencing pain, I'm experiencing brain fog, I have all these different things, where a provider might minimize those symptoms and might say, well, you know, it's not, maybe it's in your head, maybe are you really experiencing that, and questioning, and maybe they even misdiagnose, or maybe you're in a situation where a person might be in a situation where they are presenting and saying, I have this diagnosis, and there is an attempt to re-diagnose, even though a person has an established medical history. There might even be a refusal to treat, or a refusal to provide appropriate tests or to provide adequate treatment. But with that said, there are actually multiple layers that come with medical gaslighting. So first of all, medical gaslighting there can be an element where a provider makes assumptions about the patient's race, about their gender, about their sexual orientation, about their social class, anything like that. And so then they base their treatment on that. So an example of that is, let's say that someone shows up to an appointment and maybe they just got off work at a job that was really hard work, and they maybe are just a little bit disheveled, and they show up to the appointment and they're talking to the provider, and maybe the provider thinks, oh, this person, oh, they must be poor, so I'm not going to provide them with the quality of treatment that I would have provided them had they shown up dressed up with all sorts of fancy jewelry or whatever on. There's also an element of labeling that happens. A person might be labeled drug seeking. So whenever we talk about with lupus, somebody might go and they might say, hey, I'm experiencing all this pain. And especially in the pre-diagnosis phase, before you actually receive a diagnosis, there might be labeling that happens where a person is labeled as drug seeking, where they might be labeled as histrionic, where they might be labeled as non-compliant. There could also be where a person receives a mental health diagnosis, but without a referral to a mental health professional. So a practitioner might say, oh, well, you're just depressed, or you're experiencing anxiety, but they're not referring that out. They're not confirming that with a professional. They're just saying, well, this is what it is. And so essentially it's in your head, and they might attribute it, might say, well, this is just a psychosomatic thing. You have this rash. It's psychosomatic. It'll be okay. Just you get some rest, go on a vacation, eat some vegetables, and it'll be all right. There might also be an element of ordering unnecessary procedures or testing based on assumptions. So, for example, someone who might be gay or lesbian, they're presenting with a rash, they're presenting with mouth sores, and based on assumptions, based on that person's sexual orientation, or perception of that person's sexual orientation, a provider might order an STI test for someone. And the issue could be lupus. The issue could be that they're having this rash or they're having these sores because of lupus, but a physician orders an STI test and then doesn't do the other adequate testing that needs to be done to confirm a lupus diagnosis. There might be where we say that there's not where there's tests or unnecessary tests. There might be an out-and-out refusal to do any kind of lab work, any kind of tests, any kind of imaging, because again, it might be, well, I don't think that person can afford it, or well, it's actually, I'm gonna give them another diagnosis. It couldn't be this. It could be something else. And really, a lot of this comes down to refusing to believe the patient. And so there's elements of, even whenever a person has a diagnosis, refusing to believe them if they show up in a situation like an emergency room, or if they're in another care situation, and you're saying, I have lupus, or I have sickle cell, or I have whatever, and look at my medical records, and the providers don't pull those medical records. They don't listen to what medications that you're on. Someone who's in a pain crisis, maybe they go to an urgent care, or they go to an ER, and they're being labeled as drug seeking, even though they've said, I have lupus, I have sickle cell, I have whatever thing it is, and I need treatment, I need help, I'm sick. And that can even happen in the pre-diagnosis phase, where a person doesn't have a diagnosis, they just know, I'm feeling really, really bad, and I need treatment. And they don't believe. A person can be bullied, and bullying is a huge part of gaslighting, where a provider might bully, they might minimize, they might start to, if a provider maybe feels a little bit confounded by what a disease is doing, or by the course of a disease, where there can be some projection where a person might feel shamed or blamed for their condition. And really, it's any type of behavior that would strip a patient of their agency. And so an example of this, a kind of I guess it's maybe still pop culture, but not really example of this, is there is an episode of the 1980s sitcom, The Golden Girls. The title of the episode is Sick and Tired. And one of the characters is experiencing a whole bunch of symptoms that her doctor ignores. And she goes through a battery of tests. She gets a bunch of referrals, and she's told to get a haircut, and that some of the things that she's feeling is part of getting old. Well, come to find out, this character had chronic fatigue syndrome. And so I think that is a two-part episode. I think that that's something that if you want to see medical gaslighting, that's one example. Of course, it's a white woman. So there's some limits that we can have to applying that to the Black community or to other communities. So whenever we talk about identifying the medical gaslighting, I really think about that on two levels. So first of all is your feeling, your intuition, but also your interactions. So in your feelings, are you feeling like you're being believed? Do you feel like whenever you say things that people are actually believing you whenever you say it? Do you feel like you're being understood? Or are you feeling like you're being belittled or minimized or manipulated, or maybe people are misunderstanding you, or maybe they're asking you questions or something that doesn't seem to line up with what you just told them. Another thing would be some of your interactions with your providers. So again, are you being asked questions that have nothing to do with your symptoms or treatment? So are you being asked a question, you say, I'm feeling tired all the time. My brain feels foggy. I'm feeling depressed. And then your provider says, did you just break up with your boyfriend or something like that? That doesn't really have anything. That doesn't have anything to do with feelings. I mean, yes, there could be some connections there, but it doesn't really have anything to do with what you're saying. It's like, I've been feeling this way for years. That doesn't have anything to do with that.
Right.
It can also be an element of where you're constantly, of course, going to the doctor, you're going to repeat yourself a lot. That's just part of the thing. But whenever you find yourself constantly repeating information that your provider should know, and you're having to even remind them in ways of what your condition is, or correct them, or that type of thing, those are some things to look out for. If your provider's interrupting you whenever you're sharing about your symptoms, whenever you're sharing about your experience, and they're interrupting you, they're not letting you get a sentence out, or they're trying to finish what you have to say for you, rather than listening to you as a patient, or they make assumptions about you and your condition. They just come in and just rattle off a bunch of things, and you're like, I'm not experiencing that. No, like these are my symptoms.
Right.
And then again, that refusing to run tests, that refusing to do their due diligence.
Right.
What can you do?
Yeah.
You can keep a journal.
Right.
You can log, you can do all that type of thing, and where possible, have somebody go with you. Advocate for yourself. Those are the kinds of things that you can do to actually help you in that situation.
Well, thank you. That's great, Ms. Henny. And I think all our viewers here were probably nodding their head and can affirm to everything you said, that we've been there. And with the work that Dr. Rhodes is doing, we can, hope that will lessen in the years to come. Dr. Edith, it is known that lupus is a disease that mainly affects women of color. Historically, African American women have very low rates of enrollment in clinical trials. What have you found to be the biggest barrier to enlisting women of color to be a part of a clinical trial? And how might medical institutions improve their processes to increase engagement of women of color?
Sure. I think that a lot of that rests, as I was saying before, in the trust that's been built between communities of color and medical institutions to begin with. But in my personal work, what I've found to be the biggest barrier is information. that our surrounding communities are not armed with the information about trials, about various research opportunities, about other opportunities to be involved in the research process in general. And I know there are a lot of efforts, even at the national and international scale, to be more inclusive of communities of color. But I think when we're talking about specific medical institutions, there needs to be an intentional effort to really pound the pavement and partner with these communities on the ground to get the information there. As a faculty member of color, a lot of times I'm called to the table for that fact. It could be a very unrelated study, but they need a Black face to bring to the community, to try to engender some support and comfort within the community. But I may not necessarily be an expert in that area. And I have to let my colleagues know, well, I can help to educate you about appropriate ways to approach this community, but you're the expert in this area and they need the information and the expertise that you have. They need you to share that with them directly. So I was speaking about our rheumatology team that's just outstanding. And one of the things that they do is they immerse themselves in our surrounding communities of color. So they don't just show up when they need participants in a study. They're there for health fairs. They're there for other faith-based events. They're there for different educational opportunities. For instance, we have a large Gullah population in Charleston and in the outlying Sea Islands. And so they will be at some of those festivals. They will actually show up with their families. So our communities see them and they feel comfortable approaching them for information. And then our rheumatologists actually make connections with leaders in the community, with members of the community, so that whenever there are opportunities, they have a conduit to get that information out there. But it takes that kind of effort on the part of the medical institution to be really doing that kind of work. You can't just expect people to get this type of information by osmosis. They really need you to go out there and put it in their hands. And they need it to be communicated in a way that makes sense, that they understand, and then that they can respond to, they know who to contact. So it needs to, all of those things need to be involved in that process. So our rheumatology team, as I said, have made those steps, but I think that's definitely something that other institutions, other groups can adopt.
Right. Thank you. I think it's safe to say, we need the medical community and others need to earn the trust of some of the communities, they serve. Thank you. Dr. Rose, providing access to care for traditionally underserved and overlooked communities of color is one of your most important initiatives at HSS. Can you kindly share the resources and community program that you're offering to enhance health and self-efficacy in those areas?
Absolutely. And before I get into that, I just want to commend my colleagues on such brilliant depiction and answers to their question. I think one of the things that I would add to what Dr. Williams just said is we have to value our communities. And we oftentimes are going into their spaces, seeking their knowledge, and then we leave without returning with any information and closing the loop. Or then we leave without even providing opportunities for compensation, for them to sit on our boards, for them to be a part of our studies from the beginning, right? And so patient participation and patient participatory research is something that we're heavily focused on because we cannot create programs without our communities at the table. Right. And so it's important for us to understand, as I move into the question you just asked, that lupus is an illness that disproportionately affects women of color, right? And when we talk about that, what do we really mean? What does that really mean? And so just to give you a snippet, right? Lupus affects women of color 2 to 3 times more. African Americans, Hispanic, Latinx women, Asian, Native American, Alaskan Natives. And so it's important for us to understand that this core population is bearing 2 to 3 times the burden of this illness. One of my colleagues talked about gaslighting and someone going into the hospital room or going into a doctor and explaining symptoms and being dismissed, because we know lupus is little known in many communities, and even some of our rheumatologists don't specialize specifically in lupus. So oftentimes people are saying, well, you're fatigued. Well, maybe you're being a little lazy. Or maybe you're not really telling the truth about having all these symptoms. That's because they're not familiar with the disease area and how it affects your bodies. And so I was shaking my head at that answer, because so many of our lupus patients experience that invalidation of symptoms that's so real to them and so palatable to them. And oftentimes they can't point to a rash. They can't point to a sore, but they know that I cannot get up out of my bed even when I want to, right? So it's important for us to understand the magnitude of lupus in the lives of the people that we're talking about. Study shows that Hispanics develop lupus at a younger age than people of other ethnic groups, with more severe disease progression. Right? One of the most prevalent complication of lupus is kidney disease. And 49% of our Latinx women have kidney disease, and it's worse than their white counterparts. 1 out of 4 adults with SLE may suffer from major depression, right? And that's something, when you're explaining major and clinical depression that's debilitating to your ability to work, to your ability to provide, to your ability to live your life in a way that you're accustomed to, that's not often understood by the clinician in front of you, right? And depression could even be an artifact of your lupus, right? So it's important for us to understand that. And even in COVID-19, more prevalent is the prevalence of suicidal ideation in our young people with lupus and our young women of color. So they're coming in with all these symptoms that are physical, but also the mental health burden of having this illness. Our programs, Untitled Lupus, was specifically designed for people who identify as Latinx and African Americans. It's a unique support and education program with a peer component. And I will tell you, the peer component was so critical to us, because people that have lupus knows what people with lupus are going through. And for the Untitled Lupus program, we operated under the peer component not only for lupus patients to talk with and identify other people who had lupus like themselves, and to feel a sense of validation and to feel that sense of identity, like, I'm not crazy and this is not in my head. We also partner with hospitals across New York State, where our peer health educators are a part of the medical team, where they're helping our rheumatologists, our clinicians to understand the person with lupus. They're in the exam room. They're helping them to understand some of the cultural nuances, some of the traditional and complementary therapy, and finding ways to broker with the doctor that Western medicine, right, and my grandma's concoction, of herbs can exist together, and I can have a truthful conversation about that. Our peer health education program is also focused on empowerment, where we coach lupus patients to talk with their doctors about their concerns, to ask specific questions and be empowered in the appointment. So it's just not like, okay. And when I get home, I don't do any of it because I don't trust you or I don't believe in your treatment plan. Additionally, our Charla program provide materials that are bilingual English-Spanish, and all of our counselors who provide ongoing support over the phone for free for anyone who call our line, that information and support is also bilingual. Our second program is called the Lupus Asian Network. And that program focuses on our Asian American population, where we do similar things in terms of support, education, and really moving through that peer model. Our focus in the Asian community especially is to educate our providers, especially when there was no word for lupus, right? So we focus on not only educating our patients and helping them through the lupus journey, but really educating our providers. So those are two of the more specific programs that we have for those populations that's laser focused on many layers of the lupus journey, from the clinical encounter to the personal encounter to the community education level. And both of those programs are free of charge to anyone accessing those programs.
Well, that's exciting, and we'll definitely share that information with our viewers today. And again, as I think we all who are, lupus patients can relate to everything you said. I personally had my pulmonologist tell me that if anyone ever tries to tell you, Anita, that they know everything about lupus, they're wrong, because we're still learning. Ms. Henny, in our current climate of popular platitudes like, can we meet in the middle, forgive and move on? They seem to be trending in regards to addressing injustices of the past. Do you feel it's possible to achieve racial reconciliation without accountability? First, or at very least, admittance that there were and still are biases and structural racism in place.
I don't think that it's possible to achieve any measure of healing without accountability. And oftentimes people who are in positions of privilege see accountability as punitive, and accountability doesn't, there could be punitive elements. For example, maybe losing your job, your license, your position. It just sort of depends. There can be aspects to that, but the idea of accountability isn't to directly be punitive. It's rather to bring attention to the injustice and acknowledge the injustice, and then to make that injustice right. So whatever that looks like. Both of my fellow panelists mentioned here the issue of trust in the African American community specifically, but even among people of color in a broader sense, where they might trust their grandmother's herb concoction more than they trust the doctor. They might not trust the people doing the clinical trial in their neighborhood, wanting to do the clinical trial in their neighborhood, but they might trust their aunties and their grandmother and their family members who are telling them don't participate in that. And so we have to acknowledge that mistrust comes from a system. It comes from actions that are taken in the past. And until people are held accountable, until systems and structures change, it's going to be very hard. Just specifically whenever we're talking about lupus, but even at a broader sense, and whenever we start talking about medical racism, and then you extend that circle out even farther to just general racism, it's going to be very hard for there to be any type of trust, any type of healing, any type of reconciliation until accountability happens.
Right. Thank you. Dr. Edith, your work as the core investigator for MUSC Center for Health Disparities Research includes addressing barriers to healthcare in the BIPOC communities and improving clinical trials participation. Can you share with us more about your research programs and the data you have collected thus far through your past and current initiatives?
Sure. So as I shared at the beginning, my research is mainly focused on behavioral interventions to improve outcomes and quality of life in mainly African American women with lupus. And those interventions have mainly focused on improving self-management strategies. So helping African American women to identify and practice strategies that will help them to manage their lupus better. And those involve trust building activities as well. So not only those basic kind of recommendations, such as understanding your medications and things like nutrition and physical activity, but also having effective communication strategies, understanding that it's all right and appropriate to advocate for oneself, not only with your providers, but within your families as well, and with your spouses and children. And then also dealing with some of those very difficult issues around feelings of discrimination, and how do they get around those things to make sure that they're receiving the best care possible when they do need to reach out and utilize the healthcare system. So all of those different strategies have been rolled up into these intervention programs that generally run anywhere from 6 weeks to now we're embarking on a program that covers a span of 6 months, where we have sessions either in a group format or one-on-one sessions. So earlier in my research agenda, we began with smaller groups of ladies, maybe between 20 and 30 ladies who would get together on a weekly basis and go through some of the structured education around self-management, and then we would track their outcomes. And eventually we have transitioned to a peer mentoring model, where we're now matching African-American women with lupus who are veterans who have had a lupus diagnosis for some time, and can then serve as a support for ladies who may not be managing their illness as well, or may be more newly diagnosed, and helping them through their journey in a partnership, in a mutual kind of way, where both of the ladies can journey together and go through some of these self-management strategies to try to improve not only the management of their own illness, but their quality of life and their ability to seek care effectively for themselves. So that's what we're actually involved in right now. That's my most recent project. It's a federally funded project. It involves about 300 African-American women with lupus who we have recruited over the span of about 3 years. And we're in our last couple of years of that project. What we've done is we've actually matched women with mentors in a one-on-one fashion for half of our ladies, and then the other half we've actually assigned to small support groups. And what we're finding is in the course of this work, that's what's standing out as the most the contributing factor that more women report as being impactful for their life is just that communion with other women with lupus. So from the beginning, we've designed these programs and refined them over time to involve more and more aspects of interaction and relationship building within this community. But now we're seeing in our data that those women who are part of these small support groups are having just about equal gains in health outcomes as our ladies who have been assigned one-on-one mentors. So we're finding that that is that critical piece. It's them feeling comfortable enough. It's them building these relationships with other people where they feel empowered, they feel confident enough to speak with their healthcare provider, to actually challenge some things that they may have been told, to challenge some of those experiences of being dismissed, and seek out care where in other areas they may have just accepted what they were given, where now we see women advocating for themselves more and more. We've seen huge gains, not only in health outcomes, but even social life outcomes, where we see women blossoming and really embracing their condition, where they're transitioning from more of a fatalistic attitude to one of hope and setting goals that they may not have felt as confident setting before. So these are things that are coming out of that work. And as far as moving beyond where we've been and where we are right now, we're constantly taking in what we're seeing around us. And something that we're seeing are other populations within these communities of color that are still suffering, where we're still seeing them come into our hospital system prematurely with very poor outcomes, with these life-threatening complications. And these are mainly our very young African-American women and our African-American men. And what we're trying to do going forward is to work on ways to raise awareness in those populations and give those populations the support and the encouragement toward earlier diagnosis and earlier treatment, and just that confidence to advocate for themselves in their journey, whereas they've been absent in a lot of the research that we've done to date and a lot of the programmatic efforts to date. So we're using, of course, we're getting these great results in these populations that we've been working with for years now, but we now want to take that knowledge and apply it to these populations that are also marginalized, but have also been very underrepresented in our scientific work.
That's really encouraging. I think it encourages all of us to hear that. Dr. Rose, as stated earlier, lupus is a disease that affects primarily communities of color. And we have they're diagnosed at a younger age, as you mentioned earlier, and their complications are much more serious and have a higher mortality rate. How has your research and initiatives at HSS addressed these specific areas? And are you optimistic about future medical outcomes and treatments?
Absolutely. I'll go with the last question first. I am indeed optimistic. Across our nation, we know the goal of clinical trials is to discover new and better treatment for diseases, right? But it's also important to recognize our gaps. As Dr. Williams was just saying, minority participation in clinical trial is very low. Latinx people represent 16% of our US population, but only 1% of the clinical trial participant. African Americans represent 12% of the US population, but only 5% of clinical trials. And that means our voices are not heard. So what Dr. Williams and myself has partnered to do on her research is to encourage and actually to create pathways for people of color, especially women with lupus, to be able to be identified and have a voice and a stake in the research arena. Our hospital continues to partner with others like Dr. Williams to ensure that we are going into communities, going to where people live, work, and play, not expecting them just to come to us, to include them in our research endeavors. Participatory research is one of the things that I champion at our hospital. And I think that continues to give us hope about the education of patients, that they are informed, that they are specifically reached out to and invited not only as trial participants, but as true partners in the process of research. I want to talk a little bit about our program and our research for lupus in men, right? Because we often know that lupus disproportionately affect women 9 times more than men. However, SLE in men represents 4 to 22%. Of that population is represented by male. We know in a pilot study that we did here at Hospital for Special Surgery, focused a lot on Hispanic and African American males, we found that masculinity or cultural stereotype of machismo suggests that seeking care or asking for help was weak. So the perception that some of the men in our study held prevented them from moving into seeking appointments or adhering to treatment, right? And doing things that felt more aligned with their identity, because no one really talked with them about what lupus is, how it manifested, and how it might change their lives, and really normalize that. right? So it's important for us to normalize how an illness can affect you, especially for our male population with lupus. We know that mortality rates are higher among males with lupus, and males with lupus tend to seek medical attention and supportive care less than females. If you look around some of our support groups or our education groups, we are hard pressed to find lupus males with lupus, or even males of color with lupus. So it's important work that we need to really explore the barriers for males with lupus and to really continue to push to support them and help them to move into care earlier so that they can be diagnosed and treated and supported earlier. I think that's important for us and a part of our research that we've taken on to look at this specific niche population. We've also created an app called the Lupus Minder App, and you can download it on your iPhone or your iOS devices or your Android. It's a free phone application. And this app was created in tandem with over 50 plus patients of color. A diverse group of lupus patients got together and informed us about what they would like to see in an application. And most important to them were features like being able to take a picture that would depict, right, depending on the melanin of their own skin, what some of the physical manifestations of lupus were. Too often in education, there are not images that represent a diverse population in lupus. And so they're often looking and being educated by images that really doesn't represent or look like what they might experience. So they feel excluded out of the conversation, especially when we're trying to educate them. So it was important for them to be able to take photos and show physical symptoms of how lupus was affecting them. They wanted to be able to contact their physicians through the app, but also important to them was building a lupus community that they can be informed and be empowered by. So please look out for the Lupus Minder app, which is another venture of ours. We continue to also engage patients in telling us we don't do any of our interventions if our patients are not at the table. We want to know from our patients what works for you, what doesn't work for you, what you would like to see. We have more support and education programs than any hospital in the country for lupus. And it's important for us to continue to hear our patient voices. That helps to inform the diverse support and care that we provide. So those are some of the things that we do in research to incorporate the voices of diverse population to ensure we're not missing the mark and we're looking at the systemic ways that we can eliminate racism and inequities from our interventions.
Thank you. That's a lot of information. Personally, I think I want to move to your state with everything that's going on, at your hospital. Ms. Henny, pursuing justice is not a phase of life. It's a way of life. It's essential that all ethnic groups be aware of patterns of ethnic injustices that are happening right now. How would you suggest to people that they become more involved in the process of this? And as Dr. Maya Angelou once said, once you know better, do better. What would you say to us about doing better?
So doing better, a lot of that is knowing better. So it isn't just enough to know that racism exists. It's important for one to educate oneself. And there are a lot of books, there's a lot of ink that has been spilled on this topic. And so I think that education at that level is very important. Another aspect is to simply listen to people's stories. I think that's the most basic thing. If you're able to listen, if you're able to read, if you're able to do any of those types of things, actually getting into a space, a relational space with people who are on the margins of race. So that's Black, that's brown, that's Indigenous people. hearing a variety of perspectives, a variety of experiences is something that is going to make it more personal. Something that I think happens often, particularly in professional settings where people have to think about some of these racial inequities. People learn about it in kind of a clinical type way. And so they might learn how to identify medical gaslighting. They might learn some of these elements of involvement and inclusion and stuff, but then they fail to apply that in their real life. And I think that it's important for people to have a sense of relational ethics, even about how they relate to other people, how they interact with other people. And that's going to, I really believe, inform people's behavior in a variety of situations. So if you are not just practicing it in a sense of, well, these are the things, I love DEI trainings. I think that anti-racism training in the workplace is something that is excellent. But I also believe that if people don't espouse that in their personal lives, it's gonna become apparent. And so you might know how to identify something based on the rubrics of whatever training that you receive, but it's something. It's not just an action; it has to be something that's in.
Right. Thank you. I'm sure a lot of the viewers out here, like myself, are curious about COVID and lupus. And from what I've been able to ascertain from my physicians, from my rheumatologist, is that there were no lupus patients in the vaccine study. I've had my first vaccine shot, and it was Moderna. I'd like to know if any of you have heard anything about lupus and COVID. Any trial studies you're aware of, or vaccines?
We
Well,
did
I
have.
can.
Go ahead, Dr. Rose.
Go ahead, Dr. Williams. No, you go. You go.
I was just going to say that we did have some ongoing trials at the Medical University of South Carolina. I am not aware of the rate of participation of our lupus patients. I know there has been a lot of hesitation within our lupus population. And our rheumatology team has really been on board with trying to get accurate information out to our lupus patients so they can really make informed decisions. I know that a number of our lupus patients, based on the information that's been shared with them, have decided to go ahead and be vaccinated. A number of them have had success as far as not having a lot of those negative complications that we've heard about. We've also had a few of our ladies in particular actually experience COVID illness, and some of them had no symptoms, and some of them had very severe symptoms, and so they've been able to share their experiences from an illness point of view, but also from a vaccination point of view. And what we've just been trying to do is be very transparent with the results that do come across our desks, and the different guidance that particularly the Lupus Foundation of America has put out, and make sure that that's in the hands of our participants and our patients so that they can make as informed a decision as possible. But I don't know too many other details.
Thank you.
Yeah, I think that was important information. I want to encourage everyone to really seek the guidance of your rheumatologist, because as you know, lupus affects each patient differently. Each person have different manifestations, different underlying conditions. And so it is important for you to talk with your doctors. A lot of our rheumatology specific conversation around lupus patients is that the vaccine can be safe with lupus patients, but each patient's circumstance is different, and it wouldn't hurt to check in to ensure that your treating clinician is aware, and if they have any red flags for you, especially if you're receiving other injections and infusion therapies and things like that, where they need to be some delays in taking the vaccine 7 days before or 7 days after. So you want to figure out those specific nuances, right? COVID vaccine itself is not prohibited across what the academic rheumatology world is saying for lupus patients, but you want to do your due diligence and find out what's going to work best for you based on your specific symptoms and manifestations.
Exactly. Thank you. Kelly is going to come back in and join us with some questions that have been coming in while you ladies have been answering some of the questions we had for you.
Hi, ladies. As you can see, people have been commenting throughout the entire presentation, and most people have just been encouraging to what you've been saying, but there have been a few questions that have come in. First, there's one that says, is there any way that the best practices out of HSS can be elevated to be considered quality standard of care for all rheumatology practices?
I think, thank you for that comment. We have been working with our rheumatology colleagues to share our expertise and to share our successes in treating and supporting lupus patients over the years. And that's how Edith and I, Dr. Williams and I, kind of got together, because she learned about our Lupus Line program that's been in existence since 1980. And it's a peer telephone program for people with lupus and their loved ones. And so she learned about that program and helped to use information that we put out, the evidence-based practices, to inform the PALS program and to go on to receive her grant and to do a lot of good work in the community. So we've been liaising with several different organizations. We're very active in the American College of Rheumatology and continue to partner with other organizations to share our evidence-based practices. We've published vastly in this area, and we continue to collaborate with community to share and inform and to learn about how we can enhance our own practices as well. So we continue to be on those policy boards. We continue to push for patient-centered care. We continue to push for patient participatory research. And also we're on the Capitol Hill advocating with some of the best advocacy groups for difference in treatment and FDA recommendations. And so we continue to do that work to partner, and we hope that our practices and the interests of our patients continue to be elevated to national standards.
Thank you.
Thank you, Dr. Rose. Here is another question coming from Robin. She says, does anyone on the panel know how those of us warriors who are searching out help for mental health find a therapist and one that understands lupus and autoimmune diseases?
I know that I was waiting to see if Dr. Rose would jump in.
Yeah.
I know that in
Go ahead.
I know in our experience, we kind of address this on a case-by-case basis. Because again, as Dr. Rose was sharing, while everyone's lupus journey and lupus experience is different, the mental health impacts can be very different as well. So whenever we have these types of concerns with our ladies, or we get specific requests, we will actually try to work with them to identify different resources that they may be able to reach out to on their own. So we don't ever want to dictate what types of services somebody should be reaching out for, who they should be specifically targeting, but we do try to make sure that we do our due diligence in finding out all of the various options that may be available to our lupus populations who don't feel that they can approach their primary care providers or their rheumatologists for these types of services, or have hit dead ends in those types of referrals. So we try to extend our reach in searching for different options for them, and then let them sift through those options and find what may be most beneficial for them. With our program in particular, we've had ladies not only here in South Carolina, but word has spread. And so we've had a few participants in other states across the country. And we've actually gone through this process with some ladies in other areas and been very successful. And we've had a number of success stories where our ladies have been able to access services where someone just didn't go that extra mile to help them identify some of these options. So we've been able to do that, just kind of taking a hands-on approach to identifying resources for our ladies.
Right. And I will leave this information that I'm going to share right now with you, with Kelly and the team, so that they can post it. You can call our Lupus line Monday to Friday, 9 to 5 or 9 to 6, and get information specifically about the mental health service that you're looking for. We have amassed a list of mental health providers across the nation who specifically specialize in autoimmune illnesses and who are aware and have experience with working with patients with lupus and other autoimmune illnesses. So you can, if you want someone very specific, we can help you to tailor that search to a few people that we've dealt with nationally. So please feel free to call the Lupus Line. My next suggestion is the Latinx therapy group, and you can find them online. And they're a national directory of Latinx therapists and mental health resources. We've used them quite a bit. They seem very, very competent. They provide bilingual services and culturally specific and culturally appropriate mental health services as well. I also want to encourage you to maybe look at the National Alliance for Mental Health. They provide groups, they also provide support groups in Spanish and in English as well that you can tap into. But that's a nice way to cast a wide net to see what's really going to work for you. I also want to encourage you to jot down Catholic Charities. They provide case management services, financial assistance, maternal health services, and counseling. And they're often familiar with clients with a multitude of illnesses, including lupus. And that's a nice broad way to also not mental health services, but get a nice bundle of services for the needs that you may have or a loved one or a friend may have. So case management services, financial assistance, especially in time of COVID, where many people have lost their jobs and their income, also their housing. So the case management services are often helpful, and that's bundled as well with mental health services. I'm going to leave all of these programs with Kelly and the team so they can post it along with this, so you can have access to how to reach out to these programs.
Well, thank you so much for, leaving that material with us. I know we all want COVID to, get down to a point where we can, be in public and with one another. Missing the second year of Lupus Advocacy Day on Capitol Hill, going around to congressmen, that we've got work that we need to get back to. And again, I want to thank each of our esteemed panelists for your thoughtful and passionate and very informative, answers to our questions. And we at More Than Lupus, we're so glad we were able to do this today. And I know Kelly has some closing comments.
Hi, everyone. Thank you so much.
There she is.
I just want to, here I am again. Just want to thank Dr. Edith Williams, Dr. Jillian Rose, Ms. Allie Henny, and Ms. Anita Love for your time today. Thank you for joining us. And please know that this session will be available to stream later at your convenience on Facebook and on our YouTube channel. Please be sure to check out www.morethanlupus.com for more lupus updates and resources. And we will be posting all the resources that were talked about today from Dr. Jillian and Dr. Edith. Thanks again. Have a great Saturday. Bye-bye.
Thank you. Bye-bye.